branded. So now there is no need to brand yours truly. My name is Habiba or Yege or Yarekwa, and it is exactly 26 days to election in Edo State. Dr. Amagor has spent most of his personal career and business experience to help bridge the social gap that exists within the confines of his immediate society. As a primary school pupil, he was known for bringing about equality and fighting for the oppressed. Through his specialization as a family physician at the National Hospital, he was involved in many hands-on experience with non-profit and public sector environments. He understands the principles of business that brings about longevity, desirability, and profitability. He received his university education at the University of Benin and certification from various colleges, including the Mayo Clinic and Research Institute. At Mayo Clinic, every aspect of healthcare is coordinated by a team of experts who work together to provide the needed care. Mayo Clinic is consistently ranked amongst the top hospitals in the United States of America. And Dr. Amagor is a product of that institution. And he is currently the Director General of the Edo State Healthcare Insurance Commission. Dr. good morning and welcome to the program.
Good morning, madam. Good morning, Habiba. Thank you for having me on my program.
I think I like your name because you look very solid. Now, which of the Mayo Clinic and Research Institutes did you attend? Because I'm aware that they have branches at London, Minnesota, Florida, Arizona, and co.
I've done various certification with Mayo Clinic, but recently, the one that I did recently was the one at Minnesota, where we had people from cross continents, Asia, Africa, Europe, and then of course America, the North and Southern America. And were involved in various research on new clinical guidelines and treatment for various diseases. I can inform you that Africa top region came second in that clinic. The only problems we had is that our diagnostics were a little bit faulty because we lacked equipment. But in terms of technical know-how and theoretical framework, our hands on deck, African region came second in all the continents in the world.
Congratulations.
Thank you.
Now, they said as a primary school pupil, he was known for bringing about equality and fighting for the oppressed. Who were the oppressed in your primary school? I wish I was one of them.
Thank you so much.
Yeah.
Thank you so much. Right from my childhood, my immediate environment, we have seen people being oppressed, even up to primary school level, where you see people in older primary school classes oppressing the younger ones. And right from time, I've been on the big frame, I've been on the big side. And of course, at the time, it was intellectual power and muscle power. So every time I saw someone who didn't have the physical stature to stand up to the person trying to bully him, I would come in between and make sure that we disengage that scuttle and people go about their easy ways. So in my result, it was always written, please advise Dr. Rock to stop fighting for those that are oppressed instead of reporting them. So that was always written on my report card while I was in primary school, yes.
Because it was obvious that push usually came to shove, you know what I mean? Okay, now let's get back to the business of the day. What is your assessment of Governor Godwin Obaseki's health program in Edo State?
I can tell you that Governor Obaseki is a one of a kind. We haven't seen someone like this in governance for a long time. He's a strategist. He solves the problem from the root, from the fundamental, from the basis. A lot of times you see people trying to solve problems, doing short-term solutions. Okay. And then in the long run, there's no longevity, there's no desirability of such problems, or of such solutions in those problems. So Governor Obaseki is a strategist. He looks at the problem from the get-go, and he attacks it from one level to another. I can give you an example for one of the strategies I can tell you, because
Go ahead.
When you talk, I like to back my words with action. About 4 months ago, when COVID-19 started, when we started having ravaging deaths and varying symptoms for people in COVID-19, 3 days before the national body has set up a guideline, Governor Obaseki met with the NCDC people and our various partners, and we set up a response team, which he was chairing. And of course, Governor Philip Shaibu, who was the technical chair, to that forum.
The deputy governor?
Yes, the deputy governor.
Okay.
I can tell you that for the past 4 months, we have been having twice meetings daily, 9 a.m. to 11 a.m. and then 11 a.m. open. And the governor and the deputy governor has constantly been there. I haven't seen such commitment in my life.
Zoom meeting?
Zoom meeting. He has been constantly, every day, listening to what we do, listening to our challenges, bringing back his inputs. I mean, for a governor who has a lot of barrage of things to do on his hand, having that commitment to sit with us, to the nitty-gritty of how many drivers, how many samples are taken to a hospital. In my assessment in his reform program in the health sector, Governor Obaseki has done excellently well. Having about 24 hours of time in a day, doing what he is doing, I would give him an excellent, and if there's something more than an excellent, I will give him. He's such an inspiration to me, and I'm very proud and privileged to be working with Governor Obaseki. So
he's very proactive.
He's proactive. He thinks of the solution from the beginning, adapt the solution to our society. I don't want to be very partisan in when I'm saying this. I am with him because I belong to his dream. I drink from his vision. The commitment, the zeal, I mean, with all the punches he gets from the opposition, which is normal in governance, and even from his camp, he's always willing to go ahead, always willing to move further. So I want to use this opportunity to thank him very well and to tell him that God will continue to strengthen him and he should do what he's doing. It is his reform, is what he's doing that people are seeing now. That's why there's a lot of votes for him. You know, when people see what you are doing, when you are backed by action, of course they will go to the battlefield with you. You don't need to call them, and that's why you see that Obaseki has turned to a wave. It's like a movement. Everybody is longing for him. Personally, in my house, we're all divided because 90% of people are fighting for Obaseki, and the older ones are fighting for the new generation. But we tell them, back what you are doing with proof. And so I will live with Obaseki. I will stay with him. I will work with him as long as he begins to continue to inspire the people. As long as there's outcome, I think I have scored him 100%. If we can do that, I'll score him 100%.
Thank you.
Yes.
Now, what, in your opinion, are the key reforms made with the, within the made in Edo State to improve the healthcare program, and how do you think that this will guarantee healthcare for Edo people? Will it be sustained at the end of the day?
Yeah. Remember when you asked me about the assessment of Governor Obaseki, and I said Governor Obaseki is a strategist. Yeah. When he started, because of the decay that's been happening in the civil service and every facet or every MDA in the society, he focused on four programs in the health sector. Okay. One of the programs was the primary healthcare centers, the secondary healthcare centers, health financing, where I'm the Director General of the Edo State Health Insurance Commission, and of course health education. Okay. Under the health education, you have the School of Nursing, School of Midwifery, and of course the School of Technology, where we churn out a lot of medical practitioners to act as support staff or support system for the various healthcare facilities. Okay. In the primary healthcare system, when we started, because of our target to have universal health coverage, we knew that there was a lot of manpower deficits. I can tell you that in Edo State, we have over 500 plus primary healthcare centers. But one problem has always been that we have not had some form of intersectoral collaboration. A lot of people have been working in silos. So you see some places where you have facilities, but there are no manpower to run them. So Governor Obaseki, what he did was that we started primary healthcare to start galvanizing them and consolidating all their processes in one house. They call it primary healthcare under one roof. In that primary healthcare, one of the things that Governor Obaseki said was that if a primary healthcare is delivering service, it should have prerequisites to deliver such services. And one of the things was that they will put lights, electricity in those areas, manpower, adequate manpower to run those facilities, and of course, health management information system where everybody's data, because we know in the present day 21st century, our decisions are driven by data. That's the only way you can reduce expenses and then, of course, meet the demands of the populace. So we have done 20 in the first phase, and in the second phase, by meeting Sustainable Development Goal 3, we're going to do another 66 this year. Let me tell you that most of those primary healthcare centers have alternate power sources and water supply. Those are the first things first. Nobody will go to a hospital and then there's darkness. Nobody goes to a hospital and then you cannot access the patient's card. Of course, it's like going to the market or going to the farm without a cutlass. Okay. So we started doing that, and we're presently in the second phase of rehabilitating about 66.
But what about where you had a manpower and you didn't have the equipment to back it up?
That is also being reformed. Like I told you, the first 20 I just said now, after the electrification of those hospitals, portable water supply, we're delineating manpower. Remember when I talked about the primary health care under one roof? There have been bottlenecks because of the governance structure with which it was set so many years ago. And so we're trying to rejig that now so that the agency will be under one roof in terms of wages and salaries for the workers, in terms of provision of services for the healthcare centers, in terms of even moving staff from one local government or one area to other, depending on the clinical needs of the people within that society. You know, so he's been doing that reform. This kind of structure he's doing is a self-sustaining structure. So as much so whether a next person comes in, there's continuity of purpose. You know, many times we find out one administration comes in and the next administration comes in, we have breakages in what we are doing. Yeah. And so we're not properly harnessing what we are doing. We have a lot of structures, but we need to post manpower there. We need to harness everything that they are doing so that those institutions can be strengthened. And I can tell you that's what Governor Obaseki is doing. On the secondary health side, we're saying we've put one secondary healthcare facilities in the 3 senatorial districts, in the 18 local governments, and eventually one secondary healthcare facilities per local government. Okay. So that will also reduce the churning of work that primary healthcare centers are doing. Okay. Then on the health financing that I've become the Director General, a lot of things are going on. It's not a one jacket stream. I can go on and talk for that. And then, of course, again, the education where the nursing home comes in, the house midwifery homes, and of course the School of Technology. So it's an all-encompassing process. We're doing manpower development. We've trained over 4,000 staff, for example, that's going to man over the primary health care across the 18 local government areas. During the COVID, we had series of ad hoc manpower again, plus 4,000 manpower during the COVID. So I can tell you that he's a proactive governor. His reforms, we're already seeing evidence, and we hope that this commitment that we have from him will continue to foster our process, and then we'll move forward from here on. All
right. Now, these 4,000 personnel that were trained, are they taken from the 18 local governments?
Oh, yes, certainly.
All of them?
Certainly, from the 18 local governments. You do not engage people who are not in the locality where they work. That will be taking the gun and giving the gun and taking it away from them. I mean, you cannot solve an international problem with a local problem. Okay. So what we are saying is that for community participation, we are employing those within those local government areas. They are the ones that know their needs. They are the ones that know their clinical health assessments. They know the prevalent diseases in the society. They know which household is vulnerable. So they know themselves. So we are giving them governance structure and autonomy to run themselves. So these 4,000 persons are recruited from the locality where they are. Okay. And, you know, they know those who are medically inclined and those can help move the process. So it's ongoing. It's ongoing. It's a lot. Okay. It's a lot for
So as a medical practitioner, do you think that the governor's focus on primary health care is justified?
Yes. You know, the primary health care, what the primary health care stands for is it's the first line of defense when it comes to health care. When people all over the world, globally, continentally, and internationally, your first line of defense is supposed to be the primary health care. So they have a wider spread. Every locality is supposed to have 1 or 2 primary health care centers depending on the population in that area. So if you are talking about health reform, you're not going to start from an up-down approach. It's going to be from the root, from the basis, from the fundamental, and then you cascade upward. So that's why the justification for reforming the primary health care cannot be overemphasized. We're talking about universal health coverage now. It's only the primary health care that can give us universal health coverages. Yeah. It's when the services that they offer are beyond them, they have to refer to the secondary health care. So primary health care services, with the governance structure being rejigged, with the salaries and finances also being taken to an agency to take care of, you know, all this integrated payment system where you do not have to wait before you get an alert, everything is being driven by ICT nowadays. And the governor is so passionate about data because it is with data that you move your process. It is data that you plan which area needs this and which area doesn't need that. You know, so all that is ongoing. We constantly are improving our dynamism, our processes. Where there's area where we need to touch, of course, we have external consultants who have keen eyes on our processes and tell us, oh, there's a fault here, maybe we need to do it like this. And of course, our partners are also helping us as well, WHO and CDC and the likes of them, UNICEF. We just commissioned the administrative hub in the Emergency Operations Center in at Ring Road. So everything is ongoing. We're all working concomitantly.
Okay, thank you very much. Yeah. All right, Dr. Rock is currently the Director General of the Edo State Health Insurance Commission. When we come back, we are going to be talking about the health insurance scheme and how people can subscribe to the scheme. Stay with us.
If we not be Godwin, yo, we not go vote any of that person, yo.
My good people of Afemesako, election time don't reach again. Make we shine our eyes and use our brain before we vote on September 19. No forget, say, before Governor Godwin Obaseki come, local government for Edo State die patapata. Workers no get salary for many months, but Agberus them. They collect local government money, put for pocket, they marry many wives, they buy car and they build house. But God come hear our prayer and bring Obaseki come to come save Edo people, especially local government workers, from all this wickedness. That's now why we go vote for Governor Obaseki and Philip Shaibu again for this election to continue with their good mind and their good work for Edo State. So, on election day, will be September 19, take your PVC and vote for progress and development. Vote for Godwin Obaseki and Philip Shaibu. Vote PDP. Remember, say na umbrella will be the symbol of PDP. You go gum your finger put to PDP. Power to the people. Now the executive chairman, Esako West Local Government Council, Honorable Imonofi Inusa, bring una this message.
Oga, make you carry your tickets go.
All right, welcome back. Now, Dr. Rock, the governor recently set up the Edo State Health Insurance Commission, which you oversee. What is your mandate?
Okay, in May 2019, the bill with which the laws of the Health Insurance Commission was drafted was assented into law. And in that same year, later part of that year, in August, I was appointed as the Director General of the Health Insurance Commission. When we looked at the health indices and saw that the out-of-pocket spending for health in our state was on the high side, in that magnanimity and in the knowledge of the governor, we thought that we should do health financing that will reduce those catastrophic spending that the people face during times of illness. Okay. So what it did was that we set up a law and said that we're going to have universal coverage, enroll people into the scheme, irrespective of their income level, their gender, their location, their religion, or even political affiliations. Okay. So that any enrollee, if he falls sick, he can go to the hospital to seek medical care. So that was the mandate with which the commission was set up. Okay. To get these people into the scheme. When you do that, you can know the disease prevalence in a particular area. You can know the health assessment needs in a particular area. You can know the interventions to send to a particular area. We as a health insurance commission, we're a strategic purchaser of health services. Okay. So for us to strategically purchase health services, we must know the needs. And in knowing the needs, you must go to the people. You must sit with them. You must see what is going on. By doing that, you see that you cut expenditure by not involving in projects which are not necessary. Yeah. You do not buy equipment which are not necessary. In the time past, the federal government will come and just load us with equipment that we do not need, and then after a couple of years, they are outdated and we do not need them. But what the health insurance is doing is that because of inclusiveness going into this society, like I also told you, we said we're doing a lot of community participation. We want the people in the locality where they live to take ownership of this process, of this implementation. Once they've taken ownership, they know their problems. We were on a study tour at some point. We went to Rwanda, and they use very mundane approaches to get their processes right. There's something they call Garinka and Gachacha. On weekends, they sit under a mango tree, and the elders in society will call the people out and ask them what their priority needs are, and ask them what we have a list of 1, 2, 3, 4, 5. What do you think we should do? And so what we are doing here is something like that, but just in a more technologically advanced way, where we get data from our people, we see what they need, and then we direct our resources towards that area. So in so doing, we have cut off a lot of expenditures that are not necessary. We consolidate on the institutions which are meant to carry out particular functions. We avoid duplicity of functions, what have been happening for a long time. You know, you see a particular ministry is doing the same thing, another ministry is also set to do that same thing. So we can harmonize, we can consolidate and strengthen a particular institution to do that. So all those reforms are going on. That's the mandate of the commission, and we are presently in the process of enrolling people into the various plans of the various health packages in society.
So right now, what is the status of this health insurance scheme, and how do you think people can tap into it? How can they subscribe to it?
The health insurance scheme it's a very complex program. It's not a one jacket stream. Like I told you, there's continuous dynamism and continuous rejigging of your processes. No African country has done it. I mean, the best African country is Rwanda, which has 88% of coverage, and we have gone there to see what their processes are, and we have brought some of their processes to adapt to our peculiarities in our society. So we are doing a lot of underground work. One of the things we're doing is that a lot of people do not buy into insurance, even regular insurance, apart from even health insurance. So we're trying to sensitize them. One of those processes that we're sending the health insurance program to be taught in schools, from basic education up to tertiary institutions. We've written letters to the Ministry of Education to inculcate the processes or the benefits of health insurance, so that there can be a good uptake and a good acceptance of this health insurance. Sensitization of health insurance is an ongoing process. It's a moving target. Okay. You know, because every time somebody has to pay for something, he needs to know that whatever he's paying for, he's getting it. You know, we have sent letters to religious leaders and traditional rulers, over about 250 across the state. We've met with some of them. We've pleaded with them to put it in a bulletin on their Sunday services, and even do the mosque in the imams on their Friday teachings in the mosque. They should talk about our health insurance. We've gone to the various police stations and even the passport offices to put sort of deterrent, because our laws is mandatory. It says that if you are a resident of Edo State, you should be registered under the health insurance. And we know that for you to get people to register, you have to put some sort of deterrent, some sort of stop blocks. Our society is highly informal, and so we need to use various tributaries to get to our endpoint.
But did you do a jingle?
Oh yes, constantly. We're doing jingles, we're writing letters to people. We even every time, even during the pandemic, when we talk about the pandemic, we also tell people about the health insurance. Like I told you, the traditional rulers and the religious leaders are our bane. We need to ask them to tell, because they have a lot of followership.
But the jingles, were they in English only?
Oh, English and local languages.
Okay,
we did one in Pidgin English. We did one in English, and then we tried to develop one in Edo language, but we've been having a little bit, you know, because the processes are quite numerous, and so we're trying to develop them in various languages across the state, so that will be aired on TV, and then that will be taught in schools. You know, every time you meet somebody, tell somebody about health insurance and tell the benefit. Sometimes in our sensitization programs, we use examples of real life people, what they have been through. You know, they didn't have money in their pocket, and a medical catastrophe occurred. They needed to get out of that fix. But it is the pooling of funds that we started doing, collecting small premium from people that make up that funds that people will eventually use to seek healthcare in our society.
Okay.
Yeah.
Now, if you want to be part of this program, you can send us an SMS or WhatsApp on our phone number 0905-170-2571. 0905-170-2571. Please do not call, SMS or WhatsApp, please. Now, can you just walk us through the process of signing up for this health insurance scheme?
Okay. Before I talk to you about signing in, I would like to give you a little bit of background on the various health plans we have.
By all means.
For you to sign into the health insurance scheme, which is mandatory in the state, we would have to look at the person's status to see where he belongs to in terms of where he's working, his average income in a month, his family income. Is it a vulnerable person in society? Is it disabled? Is he an elderly? Is he a pregnant woman? Is he living in far to rich areas? So all those factors influence what part of the health plan the person is going to belong into. So we've developed 5 health plans basically. the equity health plan, which is for the vulnerable people, the poor in the society, that the state government and federal government are paying for their health benefit package. The
state government is paying?
Oh yes, the state government and federal government. It's a co-contribution from both state and federal government. And we're harnessing these people from the NASCO, which is the social investment program, where the national safety net from the very vulnerable people. So we mine their data for those who they've seen as vulnerable. When we get to the local government, we say, okay, give us 100,000 people. These people are going to pay for their health services through the state and federal government. So that's some form of intersectoral collaboration, harnessing various ministries to work in tandem with the vision of the governor.
So they must be captured?
They'll be captured. So for those health plans, the equity plan, are those who do not have enough money to pay for that plan. So the federal government and the state government collaborate to pay for their health plan.
Okay.
But these names are mined from the NASCO, National Safety Net Coordinating Office, where the vulnerable people all over the federation have a single data.
Okay.
And of course, the formal health plan. The formal health plan simply means those are employed by the state governor and primary and organized private sector.
Okay.
That formal health plan is going to be a co-contribution from the workers and also the government. Because of paucity of funds, what we did was that we tried to start small, take baby steps, and then once the process are improving, if we need to improve our sources, then we scale up. So in the beginning, what we did was that we took gross deductions from gross salary of 1.75% in the formal sector. I mean, those are working in the government. And of course, there's going to be a co-contribution of 1.75% of also their gross salary from the state government, which makes up about 3.5% of total salary. So 1.75 is being contributed from the enrollee, which is the worker, and then 1.75 from the employer, the government, making up 3.5%. So these deductions are done every month and then used to purchase a health plan for father, mother, and 4 children. In Edo State, we decided that a household is father, mother, and 4 children. In any case, our fertility rate in our South-West region is 3.8.
What about the polygamous family?
Polygamy is still very, very, very rampant here, but those who have more than 4 children would have to pay extra for the extra dependents in the spirit of equity. Okay. Yeah, so that's how that one is done. And then, of course, they are going to seek healthcare from public and private healthcare facilities. Okay. Then the informal sector, where our society's population is largely concentrated. You have people working as vulcanizers, entrepreneurs. They have, so to say, they have their own businesses. Yeah. This is the hardest people to get into the scheme. That's why when I was talking to you, I told you that we have put stop blocks on our process so that the mandatory scheme people can get registered into it. One of such processes is that if you want to register your child in school, they'll tell you, please present your insurance card. Like I told you, the insurance is ready for everybody, irrespective of your income level. So if you're asked to provide your insurance card, according to your status, you will get a card. If you can pay based on your income level, you will get a plan that you can pay for. If you cannot pay based on your income level, you will also be pushed to the equity plan where you can seek health care. So I've talked about 3 plans now: the equity plan, the formal plan, and the informal plan. There's also the student plan also. Oh. The student plan is going to take care of students in tertiary institutes. You know, so every year they register them into the plan until the end of the academic year before they exit the plan.
The institution will be taking care of that?
Oh yes, there's already a premium. There's already a percentage of their school fees that is already being directed to healthcare services. Well, most of these percentages have not been utilized. So as a purchaser of service, we'll come and say this percentage that they are paying, we can provide infrastructure, we can provide manpower, we can provide equipment in these institutions that these students can benefit from.
I'm not getting something right. Now, this percentage that was meant for health, has it been going on, the deduction?
Oh, it has been going on.
For how long?
A lot of schools have sick bays, but it's the strategic purchasing that's been defective. A lot of universities, a lot of colleges of education have sick bays. You know, sometimes they go there, there's a nurse there, sometimes there's no nurse there. They go there, there's a doctor, there's no doctor there.
So these monies have been deducted all along, and the universities...
Oh yes, they are providing services. Some of them are providing services. University of Benin Teaching Hospital, for example, they have a sick bay in their school. Although it's located in Ugbo campus, for those in the Kewan campus, if they have a problem, they might need to go there. So a lot of schools have that already. It's just we're talking of proper adjudication of funds. You know, once we can harness this money properly, we get an HMO that can work with them, and so they'll start getting the basic health packages for that premium that has been paid
I think, like
for.
you said, It should be taught in schools.
Oh yes, oh yes.
Yeah, so
oh,
that it will open their eyes more
oh, yes.
to what their benefits are. Okay.
And then one more last plan.
Yes,
I'm sorry to say.
you have given us 4.
I said 4, and the last plan is the enhanced benefit package.
Enhanced benefit.
Yes,
package.
the enhanced benefit package is more robust form of package. It doesn't have a lot of, it has a lot of more robust health packages than the formal, informal, and of course the student. One of such benefits is, of course, they have access to dialysis, which is capped. There's a particular amount of people. They have access to home visits as well. So we encourage those in diaspora that if you want to purchase health plan for their people, they should purchase the enhanced benefit package. Because those ones, they have 4 home visits where you can go to their aged parents, look at their drugs, make sure they're not taking too many drugs, do point of care testing for them, such as blood pressure, urinalysis, blood sugar. And aged parents who live somewhere very far away and you are working because you are trying to make ends healthcare services for that parent. And so the nurses, the doctors, the healthcare in that locality will make sure they go and see them at least 4 times in a year. So those are one of the things we are developing. These various health packages have been priced. They have been priced by our actuaries. And so once that has been approved by His Excellency, we're going to kick off in the nearest future. I don't want to put a time limit to it, but I'm sure as quickly as possible, we're going to kick off because these health benefits have been priced. Yes.
All right. Dr. Rock Amagor, the Director General of the Edo State Health Insurance Commission, is still chatting with us. When we come back, we are going to be talking about other programs that are expected from his commission. Stay with us. All right, you're welcome back. Dr. Rock, now, what services and packages are open to people?
Like I said, you know, these various plans have various health benefit packages. One of such services are child and maternal health services.
Good.
You've heard of the program Save 1 Million Lives. That was also brought by the federal and state government to reduce the maternal mortality and child indices.
You want to talk about it a little?
Yes, I will. So that service, those services for the maternal and child health covers any pregnant woman and children under 5 years old.
Okay.
We see that mortality from children occur usually before their first birthday, highest mortality, and then the other ones occur after their first birthday up until their 5th birthday. So one of the highest causes of mortality for children in our society, diarrhea diseases, prematurity, and infections, respiratory tract infections, and malaria.
What about meningitis?
Yes, meningitis also, but especially that's very prevalent in the northern part of the country, not as much as we have it here. Yeah. So those services are one of the packages we've had under our health insurance system, where even the people in the primary health care centers can give those services on a first-hand basis. Other services include internal medicine. We do surgeries for a lot of people. Even under the basic healthcare package, which is the equity, we have surgeries for children in terms of hydrocele, in terms of appendicitis, and the likes of it. We have surgeries for women, cesarean sections, ectopic pregnancy that can cause, loss of lives.
Yeah.
So those services that can shut down lives are given free of charge in our scheme. One of the things that we also did in the Insurance Commission that the federal government is now trying to start doing is the setup of the National Emergency Ambulance System. Before now, Governor Obaseki has set up his own. We have ambulances going into the rural areas. So what we did is that we developed various ambulances for different terrain. We have ambulances that are in form of tricycles. We have ambulances that are in form of buses. We have ambulances that are in form of helices because of our various terrains to get to that area. Okay. So the federal government coming down with their policies now is actually in tandem with what Governor Obaseki proactively did before, their policies have now come. So what we're going to do now is to marry those services and make sure that this health plan, whether equity, whether students, whenever emergency comes
whether
up,
formal or
informal, whatever plan, these ambulance services will be given to them so that they can get health care. There's a toll-free line, I think it's 111 and 121 in the country. With the talks last time, I knew they were trying to activate it, but I can say for sure that we have a lot of ambulances on ground that we're using to deliver healthcare services. Other packages in the healthcare services are also for hormone disorders, but those ones are usually paid for in the enhanced packages, like I told you. The enhanced package has a lot of more healthcare benefit because of the premiums that they pay, which is higher than the other ones. Okay. Dialysis service, but we do not have plastic surgery service in our...
But you have chemo.
We do not have chemo as well. The reason is that we see that there are a lot of cancer cases coming up now. And so Governor Obaseki is trying to set up a cancer center to see how it runs for a while before the insurance health can buy into it. Okay. There's a lot of spending in cancer therapy, so we have to be on a learning curve. Like I told you, the man is a master strategist. We have to be on a learning curve first to see what the utilization is, what the spending is, what prevalent cancers are common, what drugs we need to buy, what radiotherapy, machine and chemotherapy drugs we need to give to. So once we have that on a learning curve for a year or 6 months, we'll now say, okay, this is spending is educated to this cancer treatment, so the health insurance can now start putting it under their package. And in any case, if we're going to put it on our package, because I told you the spending is more, it's going to be put in the enhanced package and then eventually scale down to the formal sector, the informal sector, the student and the other plans.
Now, which hospitals in Edo State are having these schemes built into their systems?
Yes, that's a very good question.
Thank you.
I was hoping that was going to come because we keep talking of health service delivery.
Yes.
You need a hospital to deliver those services.
Yeah.
In the course of our conversation earlier, I told you that 70% of the healthcare services being provided in our state are given from private healthcare facilities. The institutions that we've had in government institutions have been somewhat not been very active over the couple of years that government has been running. But we said even the Bible recognizes it, start where they're out. And so we're saying if private healthcare services are giving healthcare service to our people, we can also engage them in our scheme. Whether you're private or whether you're public, it is the responsibility of government to give security and welfare to a citizen.
And service delivery.
So we have engaged with private healthcare. We have about 20 private healthcare schemes in our society now, equally distributed across the metropolitan in our city. Yeah. When we talk about metropolitan area, we're talking about Oredo local government area, Ego local government area, and of course Ibobaoka. When you start, you do not start big. Sometimes you might get choked up. So we're using those 3 local governments to start, having about 30 healthcare facilities, primary, secondary, and diagnostic. We'll see what they're doing, and then before we cascade down to the other local government areas. So in those healthcare facilities, one of the things that the governor said that for the private healthcare to get involved, they will have just the same thing that the primary healthcare service have, constant power supply. In having constant power supply, you must have power supply from BEDC and an alternate power supply. It can be NEPA, it can be solar, it can be generator, just an alternate power supply. And of course, water supply. Anywhere there's no water, of course, you're going to have filth and dirt. Okay. So that's what we're also doing in private healthcare facilities. We've gone there, as of today, we've gone to about 127 private healthcare facilities, a form of pre-accreditation and validation. Most of the private healthcare facilities we had have been registered in the state We went there and found out that some of them are not in that location, some of them have relocated. So we are going there by ourselves. We want to see them. It's not just to give us paper and say this is what you can do. We are seeing their manpower so that the quality and the confidence that we deserve to have in the Health Insurance Commission will be propagated from one person to another. You do not say you are going to give something and then when the person is paying for a service, you are giving them something shortfall of what you have told to give them. If we want the insurance to work, if we want this commission to work, we are going to stick by the principle of truth. And so whatever we say we'll deliver, we will deliver.
Now, let's take this scenario. Probably maybe somebody is brought in from Epoma to one of the private hospitals, and the person has been probably maybe a civil servant who is entitled to this treatment, free treatment, like you say, and the person is taken to a private hospital, and they are, they are very clumsy, trying to bring out the data from their base, or probably maybe there's no light, and at the end of the day, maybe due to one or two, should I say maybe carelessness on the part of the management, the person gives up. So what happens? No, because our people put money first before treating anybody. Now you're saying that they are entitled to free health care because of the insurance scheme, of which they have, or rather to which they have contributed. Now, how do you educate these people to let them know that, look, you must save this life first before you think of, going into your database, most especially when there is no light or probably there is no fuel to run the gen, because we cannot rule out these things. And we have had, instances whereby due to carelessness, or some people call it wickedness, on the part of the health practitioner, maybe because of the experiences that they have had, you call me, treat me, I go pay, and then at the end of the day, you end up not paying. But now, this insurance is trying to make things easier for us. But how do you try to talk to them to change their psyche, to let them know that health is most important, that these people, you must attend to them first before going to your base to bring out the data?
Yeah. What you've asked me now is a real life scenario.
Yes.
As a physician, I've been faced with this kind of problems over and over again. So
yeah.
It's a real life scenario that we must tackle. With the health facilities we are engaging in the Health Insurance Commission,
yeah.
One of the things that we tell them first is that if a patient comes to your facility, irrespective of whether he's an enrollee in the scheme, and he comes for an emergency service, I mean emergency in quotes, a life-threatening emergency service, or he's in dire pain, you need to relieve this person. Irrespective of whether he belongs to, is an enrollee in the commission or not, you should at least treat first. Treat, stabilize, before you go and start seeking for financing of his services. The government hospitals are already doing this. Now we are beginning, we see that more complaint coming from the private healthcare facilities. Because
the nurse on duty will tell you that their salary will be deducted at the end of the day.
Oh, no. When that complaint comes,
yes.
We have a legal system in the Health Insurance Commission, okay. A legal unit comprising of very experienced lawyers. We are no longer going to sit back and allow our people die for things that they shouldn't die for. If we have provided the adequate manpower, then the people should be treated. If we have provided the resources for the people, then the people should be treated. If we have provided the infrastructure for the people should be pleased, attended to, admitted, and stabilized first. So the government hospital, like I said, the Ministry of Health is already doing that. Every emergency that comes to the hospital, we have also told His Excellency that health is not 1 + 1 2. It's different. 1 + 1 in health can be 0.5, because a lot of times some funds will be lost into the system. Yeah. Hypothetically, I'm driving home and I see somebody on the road and I take him to the hospital. I don't have cash on me. I expect that the facility that I take that man to, they should treat first. So sometimes for those hospitals, especially government hospitals, that you expect a form of drug rotation or consumable rotation funds, you are going to write that some of these funds, we cannot rotate it because this man came as an emergency and we treated them. And in any case, there's also allocation for funds for emergency services in government hospital. So we are not just trying to introduce that in private hospitals.
Say it again, please.
Yes.
Please look at the camera and say it.
Yes, we're saying that there are emergency funds in government hospitals, that when people come to seek healthcare services on an emergency basis, whether they have money or not, they are stabilized. That's been ongoing. there's no going back. That's sine qua non.
So that means that they must use that emergency funds, because that is what is meant for.
Oh yes, anybody that comes to the hospital that has emergency services will be stabilized first without asking for funds, especially in government hospitals. Private hospitals, a lot of them are employing that now. I don't want to mention names, but we still have a lot of work, a lot of sensitization to do on private hospitals. And then we're encouraging them that if you see these people, as the scheme grows, you can please send your claims to us. After seeing these people that came down with emergency, we would pay you back. We would pay you back. If you have our health management information system and we're able to say, okay, these people came to your hospital, at what time, we have their date, if we're able to validate that they were treated in your hospital, of course we will pay you back. We will call the people, we'll have our monitoring and evaluation team, and your money will be reimbursed back to you.
But what if that clinic is not under your scheme?
If it's not under my scheme, we would encourage them to get under the scheme, but for whatever they've spent for rehabilitating those cases, we will try to pay them back. We will.
Okay.
We will.
Now, how far have you gone with engaging the HMOs, and how are they going to help to create more job opportunities?
The HMOs, the Health Management Organization, or the third-party organizations. A couple of months ago, we had advertorial on This Day and the local paper for 3 days in a row to send their application. Presently, we have about 17 of them who have applied into the scheme. One of the prerequisites we told them is that if they want to work in our state and in our scheme, we need capacity development. So we're giving them a minimum amount of people that they should employ from the state. And that we said that 90% of those people must be residents and indigents of the state. You cannot employ somebody who's in Abuja to come and work in Benin.
Of course not.
So we have also said that they should set up offices. We know in the present era of COVID, where we do a lot of ICT things and we don't have to see each other, but for some form of quality assurance, these people need to set up an office here. They need to be here physically. Some complaints will come to you physically, so you need to educate to those people physically. You need to bring some form of empathy and sympathy to those who are in dispute physically. So we have said one of the prerequisites that they will have an office in our state. They will employ 90% of their manpower in our state. They will set up strategic marketing in our state. And then you know that these HMOs, they have aggregators and sub-aggregators in their scheme. What that means is that the HMO employs people and says, okay, you as a man, or you don't have a job, can you, like a form of marketing, network marketing, can you bring 10 or 20 people into the scheme? And so that individual goes out and tells the people the benefits of the Health Insurance Commission. And 10 or 20 people are with him, and he brings them into the commission. He gets a certain percentage of aggregating those people. So it's all an economic process. It's a cycle. You know, it's teaching the people about health insurance. It's empowering them. It's putting money in their pocket. It's giving them health services. What we are doing is trying to close the social gap. You know, to remove these people from poverty line. You know, a lot of ills in our society are there because basic necessities are not there. We cannot get. And one of such basic necessity, basic fundamentals that the governor is bringing is this healthcare financing that we're doing now.
Now, what other programs are expected from your commission?
We are a young commission. We are very innovative. We have very brilliant minds working with us. And one of such that we have just thought out, we have written guidelines and policies to it is the Accident Passenger Welfare Insurance Scheme. But we do not want to bite more than we can chew. We want to start with this various health plan that we have said before we start going to the Accident Passenger Welfare Insurance Scheme. That also has been ongoing for a long time. People traveling intra and interstates have been paying some stipends. I don't know if you've traveled in public transport sometimes. You pay 50 naira, you pay 100 naira, and they give you that particular fund. We're saying there's been a law that said that, but we do not know what health services they've provided for those who have needed it in time past. So, like I told you, Governor Obaseki is trying to consolidate all our reforms. He's trying to, we don't want to work in silos. We're bringing all our processes to strengthen the system. So that's one of the things we're also trying to do. Whichever body is taking care of it, we'll make sure that whatever that money was meant for, it should be educated for what it was meant for. So in the nearest future, once most of our health services, most of our health plans start, this Accident Passenger Welfare Insurance Scheme will also kick off, where the people would where they will benefit from our ambulance service and, of course, the health service provider that we have accredited to work in our Health Insurance Commission. Thank
you very much. And lastly, what are the 3 key projects, in your own opinion, you think are worthy of securing the governor for a re-election come September 19, 2020?
3 key projects. Okay. You have made my answers very easy. I can mention more than 20 key projects. 20, and it will still be ongoing.
Okay.
In fact, sometimes I do not even know some of the projects. I read the papers and I find out that, oh, this man has done this. This man has done this. And I'm supposed to be here, I'm supposed to know. One of such projects is the Edo Best program, for the educational program.
Okay.
We see that people are learning from home without having to have internet. They can download their syllabus. We see that teachers are going to school when they should be in school. Their syllabus are now constantly being updated. They're using 21st century syllabus to address 21st century solutions. The teachers are no longer acting in isolations. Whenever a teacher comes to work, he clocks in, you know that teacher is at work. Too numerous to mention. Are we going to talk of the Edo Geographical Information System, where those abroad can come home now and get their C of O in a matter of minutes to hours?
Have you tapped into the GIS?
Oh yes. I'm a beneficiary of the GIS, and so I completely, I'm in tandem with what Governor Obaseki is doing.
Okay.
The projects are too numerous. I personally visited the power plant in Osiomo, the private partnership that Governor Obaseki is doing, which is delivering about 55 megawatt. Presently, Edo State is having 40 megawatt. And in less than 3 years, a power plant is going to deliver 55 megawatt. So that means we have doubled our power consumption from a 3-year tenure. So imagine what will happen if we're able to elongate or have our 2 tenures, our 4+4 tenure. There's also an Azura power plant. It is too numerous to mention. I think what we have now is a blessing to us. I think we should all tap into it. I think we should be non-violent about it. I think we should talk on facts based on who you are. I think that Governor Obaseki is doing so well, and I pray that God continue to give him the zeal and inspire him to continue to do well. I am very passionate about what he's doing. I believe in his dream. I'm a benefactor of the projects that he's doing, the roads, the civil service reforms, the Judicial Commission, the Ogbe Stadium, the Industrial Hub. I am particularly exhilarated with what he's doing. So the reform should go on. We should give him another chance to complete what he has started.
Thank you very much.
Thank you very much, madam.
So we'll take our last break now. We'll come back. We'll visit our page to take 1 or 2 comments. Stay with us.
They should not find it difficult to get their salary. Not to talk of gratuity. Thank God today the modality that is in the very present regime of Godwin Obaseki. He has changed many modalities to be in favor of pensioners. So, this very last screen, to print and go. help many situations that they should now complete and go back home.
Before, when we want to do vision, people will bring full of documentations to come to do verifications, and I dare to say that we are the best state government in terms of biometrics now. The chairman of the pension union came in to say it's just they cannot thank the government enough. They cannot thank Governor Obaseki for this in this list